Hello, everyone. This is Ziad Sabah, and I'm the moderator of this session. Uh, I'm happy today to present today Tzvi Aviv. Tzvi Aviv is a data scientist and biochemist by training. He won several awards for his open innovation work with life science companies. And before joining Loblaw's data science health team, he developed image analysis and risk prediction algorithms in the agriculture insurance sector. Also, he worked on drug development at hospital for sick children after receiving his PhD in medical genetics at UFT. And also, he received an MBA from Ryerson University in innovation and technology. He's also a triathlete, and he enjoys making his own beer and meat. So without further ado, over to you, Tzvi.
Thank you, Zaid, for your introduction. So today I'll talk about my team and I's efforts to forecast COVID vaccination in our pharmacies in Canada. But before that, I'll tell you a little bit about myself. You heard from Zaid, but I'll add a little bit more. And also something about data science at Loblaw before we dive more into the COVID, the challenges and solutions that we encountered while working on this project. So about myself, so I started my career more as a scientist rather than a data scientist, but I was always kind of intrigued by the opportunity to work with data. I received PhD from the University of Toronto looking at RNA binding proteins. And that's before that anybody could expect that RNA could be used to vaccinate people. That's quite an amazing achievement of scientists. And after my PhD, I worked at the Hospital of Sick Children, working on drug development projects in brain cancers. I left Sick Kids, did an MBA at Ryerson, and looked at more opportunities of changing my career from scientist to a data scientist. Kind of was one of the focus of the MBA period. I started doing projects for Syngenta, a very large seed company, and not all of them were data science related, but one of them was a forecasting exercise using data science to make predictions on the productivity of soybeans, and that prompted me to start my own company, Dagantech, to deliver this as a service in the agriculture world, in corp insurance companies. I spoke actually in previous TMLS conference about that. So, but that's kind of got me thinking quite a lot about using machine learning and AI. This time it was computer vision and satellite imagery fused with weather forecast to make accurate predictions on productivity on the farms. But now I'm working full-time with Loblaw. And one of the things that drew me to work in this company is not only Loblaw is a market leader with grocery brands and other retail stores here shown on the right side of the screen, but also through the acquisition of Shopper Drug Mart, also very strong market position in healthcare-related retail chains, pharmacies, and other businesses related to health, where my passion is around taking machine learning and science and applying it in the real world and helping patients improve their outcome. As you can imagine, Loblaw is a large entity, a large company, have a growing need for data scientists covering the entire spectrum, from data engineers and infrastructure people to build the compute infrastructure and tools that enable us data scientists to work with data. And in my case, my team and my interests are in data science health, so anything to do with the healthcare related project using data science. And the immediate focus of my own team at Loblaw is on the health and even more specifically on the research and development, so projects that are more research oriented around using the data assets that we have from pharmacy prescription to retail transactions, and touching millions of customers, and trying to get insight out of these data sets, and in terms of disease states, if we can predict when disease will start, if we can look at a course of treatment, if we can predict disease progression. There are a lot of things that we can do to eventually improve our pharmacy services and improve the health outcomes of our patients. That's our final goal. And when it comes to the COVID project, so of course, one of the challenges around COVID, besides being a pandemic, is that it's a whole new product. And you heard in some of the other presentation in this conference already, it's an ongoing and known issue in retail. When you introduce a new product, and you want to find out how successful it will be in the market, most people will try to find out some surrogate, similar product or similar service that we can base our production, our forecast. It's easier to build a forecast if you have some past trends to build your forecast on. So in the case of COVID-19 vaccination, the closest things that we can find in our pharmacies are the flu inoculation. So it's a viral disease. It's not the same as corona. The virus is different. The behavior of customers is different. But our first instinct was to look at the previous records in flu vaccination to try to see what we can learn from them. So here we're showing daily vaccinations in our pharmacies for the past 4 seasons, and so some things that can emerge are kind of the dream of any forecaster is very predictable behavior, seasonalities that is again common in retail. So every fall, quite a predictable number of people come to our pharmacies to get vaccinations, and that's held pretty much well in the previous 3 seasons. What also jumps out that 2020 was a big spike. There was quite a large increase in the demand for a flu vaccination. But then above that, you get a little bit puzzled. Okay, how are we going to use this? Because can we extrapolate from what happening in flu to say what will happen here in an unknown year in 2021? Can we extrapolate from flu to COVID-19? Because we know things will be different. There'll be a lot of more regulations around COVID-19. There is a strict supply, so it's not as trivial to jump from flu to COVID-19. But what else we wanted to achieve by looking at flu is also finding out what other external data sources we can use to help us predict demand or forecast demand for COVID-19, and using kind of flu as a great exercise for that. And in here I'm showing two plots. One of them is derived from our own internal data. So these are the rate of flu vaccination we're using our customer base as the population. So how many of our customers in 2020 received flu vaccination, and these are divided by age groups as well. So we can see the older patients, 65 and above, the senior patients are more likely to get vaccination in comparison to younger customers. And we can also see the variations among the provinces, right? So we're a national retailer. We have stores in all of the 10 provinces in Canada, so we can look at variability across the provinces and finding out how geospatial locations affecting your intent to get vaccinations. So in this case, it's the flu. And we compare it also to a survey. So we ran a large survey with more than 10,000 responders, asking them, did they get a flu vaccine in 2020? And we found kind of similar trends in terms of ages. So the older responders are more likely to say that they received flu vaccination than the younger responders. We also see variability between the provinces. And also very important, the rates are not exactly corresponding to each other, and for a very simple reason, because we are not the only a place that people can get their flu vaccine. So people, and we know from also from other sources that most people most Canadians prefer to get their flu vaccination at their family doctor, and pharmacy is the second or third place where people will go to get their flu vaccination, and this reflects in the rates that we see among our customers versus the rates that we see when we just ask the general population for their flu vaccination. So taking some of this knowledge, we try to formulate the problem and the challenges and the tasks that we will be facing when we actually making a forecast for the COVID-19 vaccination. One immediate challenge was, so who is our customer? Because it's always good to get the voice of the customers. And in this case, we're talking about, when I say customer, I'm meaning an internal customer. So within our company, which team is going to use our forecast that we can coordinate with this customer. So originally we toyed around with the ideas of making this available to the pharmacies themselves, but eventually we settled on actually working with the supply chain teams that are responsible to provide the vaccines to the pharmacies. And also keep in mind that there is a separate team and separate effort to actually build the infrastructure for booking appointments and scheduling and getting everybody the vaccines as they need. Our forecast here, our effort is more on the forecasting for the demand rather than building the whole IT infrastructure to get people the booking and getting the vaccine to their arms. Another reality that we face in Canada, so we are operating in a regulated arena when it comes to healthcare, and it's fragmented between the responsibility of the federal government, which are setting a lot of the rules and are actually buying, in this case, the vaccines, to the provincial governments who are actually delivering the vaccines and making a lot of the decisions for their provinces. So our task is now more complicated because we're dealing with 10 different provinces because we have stores in all of the provinces. So we have to make sure that our predictions or our forecast will be relevant for all of the provinces that we are acting in. And the other complication here is that vaccinations in Canada, as in all of the Western democracies, is voluntary. We're not forcing anybody to get the vaccine. So we're dependent on the behavior of the public. In this case, it's very similar to other retailers and other retail forecasting projects that people, it's sometimes very difficult to anticipate the intent of the customer base, and that's what we needed to do here. So the way we approach this to solve these complex challenges, first of all, we made a certain kind of rules that will abide us and help us, guide rails us towards the solutions that will be applicable. So we made sure that we're making the forecast for each one of the provinces, so we can quickly tailor guidelines in each one of the provinces based on the guidelines of the provincial governments. But we also know that we have higher priorities for larger provinces like Ontario, Alberta, British Columbia, where we have a lot of stores there. We made sure that our forecast is done in a 5 years age groups. And this is important because we know that the governments, we anticipated from the UK and also from what we saw that is happening in Canada, that there'll be some guidelines around eligibilities that will be provided in a 5 years age groups. So we made sure that our forecasts are being done kind of in a modular way in 5 year age groups. So our customers, our users can select the relevant age group for the times that they're working on right now. Our goals from when it comes to temporal resolution was not to deliver hourly or daily resolutions, but work on monthly or seasonally kind of cadence that will allow us more time to process the data and provide a refresh that are relevant again, like we wanted to make it dynamic and be attuned to changes in the market, but also don't overburden it with minute by minute updates. And we preferred speed over accuracy because of a reality of a pandemic. We wanted to make sure that we don't sit too much on the research side of things, and we applied things as fast as possible and put it in the hands of our customers so they can use it in their daily operations. So we actually very quickly churned out a version 1 that was less accurate and only for senior, so they can start working with, while we took more time to fine-tune our second versions that have more age groups and higher precision, and it's now in production in the hands of our customers. And as I discussed a little bit in the beginning, we toyed with using flu as a baseline or surrogate, but eventually we abandoned this idea, and our most current forecasting dashboard is built on a standalone COVID-19 forecast, where we're blending our own internal data sets with some survey data that we generated to create a forecast adjusted for each one of the provinces and each one of the age group in each one of the stores as well. Another feature of our forecast is that we anticipated 3 different market scenarios. Only one is actually at play. So the competitive scenario is where we are not the only one providing vaccinations. There could be doctors, could be clinics. There are multiple players in the markets that provide a vaccination, a fragmented healthcare scenario, and this is right now the situation in all of the provinces and also in many of other countries. But we did made some forecasts as well for situation that in our case remain hypothetical. For if only pharmacies will be delivering vaccine, then of course our vaccination rates or in our stores will be higher, the demand will be higher. So we made what we call a mid forecast, which with higher numbers based on the assumptions that only pharmacies, including our competitors, will be delivering vaccinations. We also used what we call a high forecast or a monopoly forecast, and in this case it's for a single provider, and this maybe will not apply in Canada, but you can see it actually playing out in the market right now in the UK, where the NHS is a single provider and they're responsible for the entire vaccination campaign. And you can imagine that there the numbers are much more higher, because then the populations around each one of the stores is essentially the target population for vaccination. And again, a similar logic can be done to make predictions for every vaccination center if you're in a case of a single provider healthcare system. Effectively, so there is no really a machine learning yet in our forecast. But we definitely use our machine learning expertise when it comes to building data sets and feature engineering, so we can blend and put together multiple data sets from transaction history to flu vaccination to patients' data to store data. And also survey data, and blending all of this data together in a way that will in a virtual dashboard and that can feature the predictions for each one of the stores, or also aggregations of stores in all of the provinces and all of the stores and all of the age groups that we have in our customer base. And a snapshot of the dashboard is provided here. So you can see here, in this case, I selected Alberta and Ontario as the province of interest, and age group from 50 and above. And here we see an aggregation of our customer traffic, the prescription traffic in the stores in these age groups and in these provinces, as well as our forecast, our mid-case forecast, which is, as I said, pharmacy dominant, or our low estimate, which is competitive. So that's kind of the situation where we're right in. And also as a reference, the number of flu patients, again, in these provinces and in these age groups that received flu vaccination in 2020, again, as another reference point. And we also, in our dashboard, you can dive into the level of the stores and select based on several columns, including FSA or city. So in this case, I'm selecting Brampton stores and ages 50 and above. And you can see, and our customers can see now, what is our forecast for the different market scenarios for each one of the stores, and can compare stores to each other, and also compare to the historical stats relevant to each one of these stores. So what do we see when it comes to the intent of the population to get vaccinated? So through our surveys that we're running them on a monthly cadence now, we can compare the ratio of people who, of the fraction of people, of seniors who say that they're going to get a COVID-19 vaccine. So one of the things that kind of jumped out is that while on March, most of the seniors said that they're interested in getting a vaccine, when it comes to April in Alberta, you see very sharp decline. But don't be alarmed. That there's nothing. It doesn't mean that the vaccines are bad and people are turning away. It's actually because most seniors in Alberta already got the vaccine, and we can see that because we asked them, "Have you got the vaccine already?" And in Alberta, these numbers quickly went up from about 10% to almost 80% in the course of in the months between March and April. Even in Ontario, numbers are definitely going up, and correspondingly, the intent to get vaccine also going down. So everything actually here looks fine. But now the battleground seems to be shifting to the younger age group. So people from 45 to 64 are now less of them. Also, even with this age categories, there is definitely an improvement, and more people are getting vaccinated. But still, there is a lot of room to go because there is still only let's say on average about 20% of this age group said that they got vaccination. So and this is much larger cohort in the demographic than the seniors. So there are a lot of people to vaccinate. Intent seems to be holding pretty okay. Again, maybe not as high as some people would hope for, but still large enough to hint that we'll be able to achieve herd immunity. As well in the even younger age group, 25 to 44, there still seems to be pretty good intent on getting the vaccination, and a lot of room to provide vaccination. And with that, I'll end for questions. But I want also to ask you to do your part, and if you're eligible, when times come, register with our system or with another system, as long as you get any of the approved vaccines. I also want to thank the RNA biologist who worked for many years and enabled this major breakthrough when it comes to the Pfizer and the RNA and the Moderna RNA vaccines, but also, of course, the virologists that enabled using adenovirus to be used as a vaccination. And as suggested, also a question for discussion period around ideas, I guess crowdsourcing for ideas for how we can make sure that people are getting the right information for them and are not turning away or from the vaccine opportunity, so we can get a better chance of achieving herd immunity here in Canada.
Thank you, Tzvi, for the awesome session. And thank you for your suggestion of people participating in the survey and in what you're doing. That's really awesome. So Mina has a question. Actually, I think there are two questions. So why is market scenario is important to in the forecasting? Yeah.
Yes. So that's a fair question. So you kind of you would, so if I understand the question correctly, like why even bother with scenarios that seems to be more hypothetical? So again, keep in mind that what we saw with COVID-19, scenarios change very, very rapidly. So the government, if you want to take an example with the AstraZeneca vaccine, the age of eligibility changed pretty fast. And similarly, we anticipated, at least in the beginning, we wanted to make sure that if government change their mind, even in terms of the distribution, if government suddenly say, only pharmacies, for whatever reason, I guess there could be a good reason for it, because if government would say only pharmacies distribute, they don't need to hire anybody to vaccinate. They don't need to worry too much about the whole supply chain, because we already, pharmacies, not only our pharmacies, other chains have already a nice setup. We have the pharmacists working. We pay them salary. We have a supply chain mechanism. So, and we know how to distribute medication. So at least a pharmacy distribution model where family doctors or maybe even clinic will not exist and only pharmacy will exist, at least seems to be plausible. The monopolistic kind of a situation where only shoppers is being the one providing, it's less likely to happen. But we still wanted to include this as kind of maybe as an upper bound, like, right? Because it's another reason to include these more hypothetical scenarios, because if our in any of the forecasts, if we exceed the capacity of the market around the stores, it means that something is wrong with our forecast. So another reason to include the more hypothetical scenarios was kind of as a guide rail or upper bounds for our forecast in general.
All right. Yeah. So just to follow up on that, I can see. So you have blended 4 data sets from different data sets, historical ones, and regarding the flu or vaccinations and stuff like that. In your opinion, how would that, like, we don't know. So for the flu vaccination, for example, there might be no obligation or no problem with one getting this flu vaccination. Although with the new vaccinations for COVID, there might be, media stuff that encourages people to go vaccinate or not. So in your opinion, how would these historical data sets that are not relevant to the COVID situation help in this forecasting?
Yeah, so again, as I said, in the beginning we toyed around with the idea of using flu. Like, for example, we can ask people, what is your intention for COVID? We can ask people, what's your intention for flu? And then get a multiplier, say, okay, let's say 60% say yes to COVID and only 30% say to flu. Then we have a multiplier of 2, a factor of 2 from flu to COVID. So that's an idea that is potentially appealing. Eventually, we decided not to use it at all and just build on the intent for C19. But again, like in the future, maybe us or somebody else want to do more work around that, and maybe they'll be more clear. And including like one of the things that we haven't done here is looking at the individual person. Like, can we predict for you as an individual, are you likely to get your vaccine? And again, in this case, kind of a good hypothesis will be, if you already got a flu vaccine, you're more likely to ask for a COVID-19 vaccine because you believe in vaccines. But if you're but it also, the other way, maybe it is not true, right? If it could be that a person say, I'm not interested in flu vaccine for whatever, but I'm still interested in COVID-19. So there is still a lot of room to do more, to dive more deeper into these problems and try to find out what are the attitudes of people for various vaccines, and what is transmittable or transferable from one case to another. Is still an ongoing problem that I think we, as a community, we need to address.
All right. So one last question quickly. So how did you estimate how much intent would actualize into shots in arms? This is a question by Zain.
Yeah, so I mean that's why it's a forecast. It's not we don't know how much of it will translate, because we ask people what is their intent, and as we know, not everybody that says they'll get it, they'll actually get it. But from what we see with the flu, for example, is one of the reasons that we did it, because we see pretty good correlation between what people said and what people did. So that's why we think that again, like, and we provide even error of margins by usual statistical means. So we think that it will come within our error of means of margins.
Awesome. I think our time is up already. So thank you for this great session and the insights. We really appreciate that, and hope we see you soon. Right?
Thank you, Zaid. Thank you for inviting me, and thank you for hosting. Thank you very much.